Good afternoon, everybody. Today is Friday, the 11th of December, and this is our 30th webinar at UCD COVID series. I'm delighted to introduce myself, Fiona McNicholas, child psychiatrist, and my colleague, Dr. Browne Gavin. And Nora Zilaji is helping us from the UCD side, and the College of Psychiatry in Ireland are also co-hosting these webinars. It's amazing to think that this is actually our last webinar of 2020. And so I think that in some ways we might have saved the best to last. At least it's certainly coming from the perspective of child and adolescent psychiatry. Everybody is very familiar with the format now, but just to remind you, please feel free to send questions on the chat function during the talk, and I will get to these with our guest speaker at the end. And if you'd like to engage in a conversation, alert me to that and we can unmute you, and you'll be able to put the question to our speaker yourselves. So I'm delighted to introduce our speaker today, Professor Dillon Browne. Dillon is Professor at Psychology in the University of Waterloo, coming from Canada, so it's morning time for Dillon, and we're very grateful for you getting up this early to join us today. Dillon obviously spans both a clinical service in the area of child, adolescent and family mental health, and very much is leading in a research area in the area of adverse childhood experiences, trauma, and takes a very unique perspective to it, which is that of the family systems lens. And Dillon, we're really looking forward to your talk today, because I think you're going to paint a little bit of the epidemiological data from Canada, but also, I suppose, remind us of the very important multi-layered impact of COVID, not just on individuals, but on the whole systems. And I guess that probably extends to the systems that we're working in ourselves. So the title of your talk today, Children's Mental Health During COVID-19, a multi-level examination of family stress. Thank you, Dillon.
Thank you, Fiona, and thank you everyone for the opportunity to be here this morning or this afternoon, depending on whatever time zone you're in. I like this time of day. It's when I'm at my best, so it works for me. Okay, so as you can see from the title of my slide, which I tweaked a little bit from what I sent to Fiona a couple weeks back now, I'm going to be talking about COVID-19 stress and families. We've been hearing a lot about children's mental health lately, perhaps a little less about parents, and perhaps even more about entire families. So my hope is that this talk will shine some light on how pandemic stressors have been operating across the family system, especially for parents, and with implication for intervention, which will be coming towards the end of my talk. I'll talk about for 45 minutes, and then we'll have some Q&A. So I want to start off with a story about the Jensen Ramirez family. They're a blended family with both Victor and Helena having children from previous marriages. The pandemic has impacted each family member very differently. Victor was laid off and has been on an unemployment benefit, still can't find work. Helena is an essential worker, and she's been doing overtime to make up for the difference so they can afford their rent payments. At home, Mary and Louisa are attending school online because Louisa is immunocompromised. As a result, the family's been very strict with social distancing. Victor feels resentment at the added childcare responsibilities, which he feels are impeding his capacity to find work. Since the summer, his weekly six-pack of beer has become a 2-4. I don't know if you use that term in Ireland, but when we have 24 cases of beer, we call it a 2-4. We even have a weekend named after it. Helena reports feelings of exhaustion and burnout. She also noticed that it's been a few months since her and Victor were intimate. Mary has become very anxious about germs and is having daily explosions, whereas Helena is coping well. While Louisa is coping well. So Helena, the mother, has decided to seek outside professional help. She's worried about the kids, but knows that the difficulties are multifaceted. So if you were doing an intake assessment with Helena, what would you suggest? As you probably gathered from the title of my talk today, my argument is that a whole family approach, such as family therapy, that pays close attention to caregiver mental health and family relationships is particularly warranted. And to quote my colleague at another Canadian university, children will be all right, ultimately, if the adults taking care of them are all right too. So what do we know? Well, everyone knows that COVID-19 has created significant challenges for children and their caregivers. Many of you are undoubtedly experiencing some of those challenges yourselves. What remains unclear are the mechanisms through which this expansive and all-encompassing pandemic influences families and kids. Relatedly, while we're seeing differential outcomes for COVID-19 infection itself across subgroups of society, we still know relatively little about how these psychological stressors differentially influence families with different backgrounds and life histories. So I hope that my presentation today will accomplish these goals, in addition to discussing what we can do to help now and during future shutdowns as the second wave progresses. Before we get too far into the weeds, let's just take a quick look at some simple research surrounding the pandemic and mental health. You remember when you didn't know what COVID-19 was? I do. I actually had a study on the go at the time, and I was looking at socio-emotional well-being or children's mental health in the context of early childhood education. This study was planned to span December 2019, so a year ago, to March 2020. And each child in the study was to be assessed by an educator report 3 times during that window. Of course, the pandemic was announced on March 11th, and we were frantically able to finish the last time point of data collection before the lockdown. So what I've presented to you here is a sharp regression discontinuity design where means are modeled before and after the pandemic using a 3-level growth curve model to account for classroom effects. On the y-axis of each graph, we have the SDQ, the Strengths and Difficulties Questionnaire, and the Impairment Rating Scale, respectively. On the x-axis is time in days centered on the WHO pandemic announcement date. And for both outcomes, we see for boys following the pandemic announcement that there is an increase in mean levels of mental health problems. This pattern replicates if we use a fuzzy regression discontinuity design, that is where we relax our cut point to the entire month of March. So this may actually be some of the earliest evidence now that children's mental health was deteriorating as a function of COVID-19 as far back as March of this year. And these kids are now being followed up in Toronto as we speak. Now, of course, that study is very limited methodologically and also in terms of follow-up. So let's look at some rapid reviews that have now come out from my colleague Sherry Madigan's lab in the University of Calgary that brings us deeper into the pandemic. So in blue, I have our best estimates of prevalence, arguably, that is global pooled prevalence of all mental illness in children and adolescents before the pandemic, around 13% there. And in red, I have several studies included in this review, mostly from China at this point, examining prevalence since the pandemic. And for the most part, the differences are pretty striking. It appears to be operating across domains of psychopathology. So there on the x-axis, you can see that I have the study author and the domain of psychopathology that is being considered. So both internalizing and externalizing symptomatology. Moving over to adults, the same group was able to derive a pooled estimate this time of prevalence of PTSD and also general distress. So before the pandemic in blue, this is the National Comorbidity Survey from the US. And there we're seeing the prevalence rate of PTSD around 7. In Canada, it's about 9%, based on recent estimates. And then in the pandemic, we're seeing a pooled prevalence of PTSD, which is 1 in 4, which I found absolutely shocking. And we might actually just pause there for a moment to think about the pandemic as this global collective trauma that is taking place before our very eyes. Finally, on to parents specifically. This is my colleague Andrea Gonzalez at McMaster University in Ontario specifically. So 1 in 3 parents are reporting moderate to high anxiety regarding everything that's going on in their life, and nearly 60% of caregivers meeting criteria for depression based on a brief screener. Sources of concern for parents are ranging from remote learning to screen time to children's own mental health difficulties and their routines of day-to-day life. So all of these descriptives, these past few slides I showed you, are wonderfully descriptive, and they stop short of describing the mechanisms through which the pandemic influences families. And we need to know that in order to best target our interventions onto the multiple factors that are leading to difficulties in the lives of our clients. So that's what I'm going to discuss presently. I just want to acknowledge 2 of my colleagues, Heather Prime and Mark Wade, who are collaborating with me on all of this work. So earlier this year, the 3 of us developed a theoretical model outlining how social disruption related to COVID-19 influences families and children. This is an American psychologist, if you're interested. So prior to the pandemic, all families had some level of pre-existing vulnerability, which may modify the effects of the pandemic. Now, as a result of COVID-19, we have a variety of disruptions taking place that lead to compromised caregiver well-being, which then sets the tenor for less functional family relationships and lower levels of family well-being overall. Within the family, we're thinking across domains in addition to structurally, in that we have family-wide processes and processes within each subsystem, the marital subsystem, parent-child subsystem, and sibling subsystem. These proximal family relationships are then connected to child adjustment. We also argue for buffering processes whereby healthy family functioning could offset the negative consequences of the pandemic onto children. However, we have a bit of a paradox here when considering the stressors that emanate from macro contextual contexts such as poverty and disaster onto individual children. So these stressors are operative in the distal ecology in that they're shared across siblings within the same household. So many of the effects of COVID-19 on families would be similar for children residing under the same roof, say if a parent were to lose his or her job. That being said, decades of behavioral genetic research, especially the seminal work of Robert Plomin in London, unequivocally shows that siblings are more different than similar once accounting for genetic influences, suggesting that non-shared environments are central to understanding the developmental health of children during this pandemic season. So just to illustrate this, in the figure there on the right, we have variance components from the classical behavioral genetics model in terms of personality development. And after accounting for genetic effects in black, we see that non-shared influences in white, or contexts that are unique for each sibling, are more important. So how might the pandemic be influencing children in light of what we know from these genetically informative paradigms? The most obvious answer comes from studies of differential parenting, also known as favoritism or differential treatment. These studies suggest that parenting is only moderately correlated across siblings, so 40 to 80% of the variability is within families. Furthermore, we see that differential parenting is greater in low SES, low socioeconomic status households. So you can see that graph on the right there, and the amount of differential parenting or favoritism is higher when socioeconomic status is low. This is often explained through a resource dilution framework. So that is, when parent psychological resources are limited, they will allocate more attention, patience, and time or investment to the child who is easier to parent, and may lose it with the more difficult kid. So in light of this, myself and my colleagues sought to explore if COVID-19 stress augments these child-specific environments in a fashion similar to SES, while empirically exploring the theoretical model related to COVID-19 family disruption that I just outlined for you. Drum roll, please. This is our new study. Let's take a moment to appreciate this acronym, which is, I think, my crowning achievement as a researcher. This is the Cramped Family Study. Many of you are undoubtedly feeling cramped with your own families right now. I sure am. And this is a partnership with my lab, Prolific Research in England, and it's a cross-national cohort that I'll describe for you now. So today we're going to be looking at data from the first 2 time points that were in May and July of this year. We're currently analyzing September, and November finished, I think, yesterday. Okay, so we have 549 caregivers who were the primary respondent and had 2 children between 5 and 18 years of age. The younger child was on average 10 and the older was 12. As Prolific is based in England, the majority of the sample was UK British, and additional demographics are presented there on the right. We're currently looking for top-up funding in order to address a bit of a diversity issue in our sample, with the majority being white European. So our measures for this study directly map on to the framework I outlined. And just to note, these are not all of the measures that we've included in this study. These are just the ones I'm going to be talking about right now. Okay, so I'm going to work backwards here from child adjustment. So we use the PROMIS scales from healthmeasures.net to assess child psychopathology. General family functioning was assessed using the McMaster Family Assessment Device. And parental negativity, so this is like harshness, reactivity, ineffective discipline tactics, that was assessed using the Ontario Child Health Study Scales. Caregiver distress was assessed using the K10, which a lot of you might know as the Kessler measure. And that taps both depression and anxiety symptoms. And the stressors from the pandemic were assessed using a newly created COVID-19 scale, which I'll describe for you right now. All of these models are controlling for previous income, in addition to caregiver and child age and gender. So COVID-19 related disruption was assessed with 24 items that were generated from our team to look at the stressors and challenges associated with the pandemic. Some of those examples are presented for you. We literally have a toilet paper item, which I don't know if you had that same problem in Ireland, but we had, a lot of shortages on essential supplies. Disruption to finances, routines, living spaces, and so on. And our psychometric measurement exercise yielded 3 dimensions. So what this is telling you here is there's a lot of stuff going on for COVID. What are the dimensions of challenge that our families, our clients are facing right now? The first was a financial disruption dimension, and these items are summarized for you right now. The second was a family disruption factor that spoke to caregiver perceptions of changes in the family that have taken place: altercations, withdrawal, new routine, so on. And lastly, there was a pandemic specific factor with items kind of related to these unique challenges that are like COVID or pandemic specific. All of these factors were loading on a higher order factor based on higher order factor analysis. So for the remainder of my talk, I'm going to be focusing on all of these together. So the measurement of COVID-19 stress is at the family level. Though I've already mentioned that we have 2 kids per family, so we really need to be thinking about the sibling design, okay? So just bear with me here. For the child-specific measures, children's mental health problems and parenting, there are 2 scores per family, so we need to deal with that somehow. We can't just take an average. So they're decomposed into 3 parts with a multi-level modeling exercise. So I'm orienting you to 2 hypothetical families here. So on the y-axis, we have children's mental health problems. In both families, we see that sibling 1 is doing worse. The average of the 2 sibling scores yields the family average value, and the differences across households would be the between family differences in blue. The differences of siblings within the same family can be represented by an estimate of variance, like the standard deviation. So in this example, the children in family B are doing worse on average and are more different than the children in family A. And lastly, we have a child-specific deviation from the family average in green, which allows us to know which child is doing worse. Family averages and variances are between family estimates because there is 1 value per family, and the child-specific deviation is a within family estimate because there are 2 scores per family that reflect differences between kids in the same household. So that is a crash course in the sibling comparison design. Okay, so now let's look at how the data played out. So first, we're going to go through the between family differences. So these are comparisons across different households. I've color-coded these for you in keeping with the last slide. So in households where COVID-19 disruption has been high, caregivers are more distressed, families are more dysfunctional, parenting is more negative on average, and children have greater mental health problems on average. These are standardized estimates, so you can interpret these in standard deviation units. Additionally, siblings are more different in their mental health problems when COVID-19 disruption is high, suggesting that 1 kid in the family is particularly affected by the pandemic stress. So if we're thinking clinically about the families that we're working with, are there siblings involved? Is 1 kid in the family doing particularly worse than the other? And now we're going to do longitudinal effects. So I want to highlight these transactional child effects here because this is different than what we thought was going to happen. That is, when COVID-19 disruption is high, children, i.e. the sibling subsystem, tends to be doing worse. Consequently, this predicts greater levels of caregiver distress, family dysfunction, and parental negativity at time 2. So these are child-driven effects onto the family system. Moreover, the effect of family average child mental health to the family variance in children mental health suggests that this 1 child is deteriorating across the period of follow-up. That 1 kid is getting worse over time. We also have family-directed effects highlighted here. That is, when COVID-19 disruption is high, there tends to be greater family dysfunction, which predicts greater caregiver distress and family average child mental health problems the next wave. So all of these implied indirect effects that I just outlined here are statistically significant. Moving to the within family part of the model, now we're comparing 2 kids within the same family, okay? This is all within 1 model. It's a multi-level structural equation model. And now we're comparing 2 kids within the same family. So at time 1, the sibling who has more mental health problems tends to be receiving more negativity from the parents. Over time, there's a stability in children's mental health problems, suggesting that the kid who is struggling more at time 1 is also having greater difficulties at time 2. The most interesting part of the model is that directional arrow pointed downward. So that is, the child who has greater mental health problems over time tends to elicit more negative parenting relative to his or her sibling. In other words, there's a deterioration in the relationship of 1 parent-child dyad, and that is being driven by the kid's mental health problems. So let's bring that back to our family. Going back to the Jensen-Ramirez family, this would say between Helena and Mary, their relationship is really starting to deteriorate over this COVID-19 season, but not necessarily Helena and Louisa. So stated differently, thinking about one kid per family in our psychiatric and psychological epidemiology of mental health during COVID-19 will not suffice. We need to be thinking across multiple kids per family. Okay, to summarize these results, COVID-19 is getting inside the family by increasing risk across the entire household, spilling over from one domain of family life to another, and making siblings more different from one another in terms of their mental health. Within families, the child who is viewed to be struggling more ends up eliciting greater negativity from parents over time. Stated differently again, in order to understand the effects of COVID-19 on children and families, we really need to be thinking in family systems terms. Okay, that was a lot. Before we get into intervention, let's just take a closer look at the parents, okay? Previously, we saw direct effects of the pandemic on caregivers. It may be beneficial from a public health point of view to identify caregivers who are most at risk for these stressors emanating from the pandemic. Two synergistic hypotheses formed our thinking in this area. The first I call the busy mom hypothesis. This stems from decades of sociological work finding that female caregivers have a double burden, which leads to greater work-family conflict and role strain. The second hypothesis comes from the idea of stress sensitization, which essentially is a special case of the diathesis stress framework. That is, in early life, adversity can increase susceptibility to recent life stressors by lowering stress tolerance or increasing stress reactivity. Of course, there is the possibility that both of these hypotheses are working in tandem. That is, both mothers and those with early histories of adversity would be more susceptible to the influences of the pandemic. Still operating from that COVID-19 family disruption framework that I outlined for you. I'm just highlighting the measures here. I won't go into as much detail with them, all validated standardized measures of caregiver psychopathology, in addition to the ACEs, the adverse childhood experiences. Okay, so first let's do mean differences as a function of caregiver sex. Note these are between family comparisons as we only have one caregiver per family. So here we're seeing that in families during COVID-19, mothers are reporting higher levels of COVID-19 disruption and higher levels of adverse childhood experiences. On to parental psychopathology. We see that mothers are reporting higher levels of distress, anxiety, and post-traumatic stress symptomatology. Conversely, it's hard to see there, but fathers are reporting more substance use. Okay, now I'm going to walk you through these interactions. COVID-19 disruption on the x-axis and ACEs presented in dark versus light lines are presented for male and female caregivers in blue and red, respectively. In most instances, panels A, B, and D, there is not a significant interaction for mothers or fathers. That is, the effects of COVID-19 and ACEs are additive along with sex. Therefore, we're seeing the highest levels of psychopathology when COVID-19 disruption and ACEs are high, and this pattern holds for both mothers and fathers. The exception here is for substance use in fathers, where we see evidence of stress sensitization. Specifically, the effects of COVID-19 stress are only observed amongst fathers when they have high levels of ACEs. In other words, high rates of substance use are only observed among fathers who have histories of early adversity and are presenting with high levels of COVID-19 stress. So in our clients, we're thinking about what's going on now in addition to the early psychiatric history. So we have moderate support here for both hypotheses. In terms of sex differences, It's mostly about main effects, but good thing that we looked at substance abuse too. So fathers might be masking their psychopathology symptoms with self-medication. In terms of history of adversity, we're seeing more evidence for additive effects, though there is evidence for stress sensitization for fathers, keeping with this influential idea of addiction being a response to early adversity. Okay, so what do we do about it? I'm pretty good on time here, so that's good. We can talk about this for a bit. I'm excited to hear more from people during Q&A, what's been going on. I had a chance to talk with some folks about how things have been looking at the hospital and in the community mental health centers. So I'm going to provide some clinical tips that we're using with students right now, okay? And this is also something that I'm bringing into my work with caregivers. So first and foremost, I want to discuss the importance of the oxygen mask principle. That is when, if you remember what flying on an airplane was like, we tell parents to put on your mask first. Without knowing client specifics, my general recommendation here is whatever worked before the pandemic, do that. If you can't do that anymore, be creative and find the next best thing. I think this is important because sometimes in our emphasis on children's mental health during the pandemic, we can run the risk of losing sight of parent mental health and that children require mentally healthy adults in order to do well. So pro tip number one, put on your mask first. Next, for all the clients we're working with, we're telling students to prepare for children being at home again and out of school in terms of logistics and also in terms of psychological coping strategies. So different regions here in Ontario are cycling in and out of lockdown. Things aren't getting better. It's looking like there's going to be more of this in the new year. And because of this pattern with how kids are doing in school, so we actually did a simulation study with PhD student Brendan Phillips here at Waterloo in the math department. And in these graphs here, you can see on the x-axis, I have different student-teacher ratios. 8 students, 1 teacher, 15 students, 1 teacher, all the way up to 30 to 1, which is what we ended up with despite advocating from the public health community. The province decided to go with the regular classroom size of 30 to 1 for financial reasons. And these simulations show, it's not rocket science, it's a simulation. When there are more kids in the class, there's going to be more COVID-19 infection. And when there's more COVID-19 infection, you need to close that class for 30 kids. You're going to have more days missed. What does that mean for us as clinicians? That means our people are going to be at home more. More of our clients are going to be at home more, and we need to prepare them for that. So for all your clients, children and families, let's get a school closure plan going. Okay, next, what are we doing with our families via telehealth? I'm a clinical psychologist, so I cannot provide you any medication recommendations, but I can talk to you about parenting. So this is a lovely meta-analysis that just came out from my colleague Heather Prime that looked at technology-assisted parenting interventions amongst caregivers who had some level of risk. All those little black squares there on the figure are all the individual effect sizes from the study, and the diamonds are the pooled effect size. The further to the right, the better the evidence for that particular clinical outcome, whether it's caregiver well-being, parenting, or children's mental health. And we're seeing here, what is the takeaway from this slide? The slide is that manualized protocols for parenting interventions work via telehealth, and they work for both children and caregivers. So these are programs like the Triple P Parenting Program, the Incredible Years Parenting Program. They're available, they're online, you can find them. The evidence is widely available. So those types of interventions are working. That being said, across the province, at least in Ontario, there was a recent survey by my colleague Sylvan Roy, and yeah, like a lot of practitioners are moving to the telehealth medium. A lot of the work can be digitally mediated, that is. However, it's a bit of a glass half full scenario, suggesting that telehealth is not going to be a panacea. So keeping with our idea of the limits of competence, we need to know what we cannot do via telehealth. And yeah, only about a third there were thinking that their work can be 100% virtually mediated, obviously in the context of hospital work or in a tertiary care center, not all of the work can be done via telehealth. So we need to keep that in mind. There are a few areas where the evidence is less clear for telehealth. This is a brand new study I wanted to tell you about. If you invite me back next year, I'll be able to tell you about the findings for this one. So family therapy, right? It's much more established to be doing telehealth with an adult individual or even a teen individual, less so for the relational types of psychotherapy, the ones that I'm kind of most excited about. So emotion-focused family therapy is a good starting point for this work because it's simultaneously a manualized parenting intervention, and it's also something that is based in family systems. Emotion-focused family therapy, if you haven't heard about it, check it out. In September, we launched a virtual EFFT intervention study. We're comparing 2-day workshops to parent-only to whole family formats. The whole family format is cool. We have multiple family members in little squares. Some of the families aren't even living together. And this being facilitated by a tech company called Get Ahead. They're one of the many companies that are doing telehealth. And it also is supporting our live supervision of students during this time. So if you're interested in that, please reach out to me and feel free to ask any questions. In the meantime, what we can be taking from this right now is to formulate our cases, to be thinking about our cases in terms of COVID-19 stress and in terms of family systems, whether we're working with individuals or with dyads or with whole families. And I'm going to leave you with this because I wanted to give you a good nugget, something nice to walk away with. One of the key components to emotion-focused family therapy is this idea of emotion coaching. It comes from the John Gottman school of thoughts and very influential ideas in relationships and psychology. So the idea here is just like children have coaches on the soccer field or the hockey rink, if you're in Canada, any parent, I should say the football field, any parent can become the emotion coach of their child today. It involves 3 steps. I'm going to walk through them, then I'm going to give you an example, then I'm done. So first, we validate the emotion. We name it specifically, and we provide justification for why it is normal and why it is okay to feel that way. Next, we try to meet the emotional need. This is coming from the idea that any expressed emotion has some sort of underlying need, some type of information that it's trying to convey. And lastly, we provide practical support, which can involve redirection or problem solving or setting limits in the case of misbehavior. So these are skills that we're teaching parents to do with their own kids, and we're also kind of emulating these skills in our own work with our clients when our parents, when our clients who are parents are coming in and receiving parenting support. So here's an example. In this particular example, we have a young girl who is sad she has to stay home from school due to some symptoms of sickness. And an example of emotion coaching would go somewhat like, I imagine you're feeling sad because you have to stay home from school and because you can't see your friends for a few days and because it was right in the middle of an art project and you were really enjoying it. I want you to know that it's okay to feel this way. I'm so sorry this is happening. I'm here for you. When you're ready, why don't we go downstairs and get out those art supplies? We could work on your project together while listening to Frozen. So I just want to clarify that this is the exact same structure of communication that we recommend parents to use for children of any ages, or even for couples with one another. So for homework, I'm sorry to give you homework right before the holidays. I want everyone to try using emotion coaching today, and if not today, this week, with their loved ones or with their colleagues. First, by validating the emotion, then providing the emotional support, and then providing the practical support. Note that the most important step here is the validation piece. Without that, the other pieces don't work together. Now, anyone who didn't attend this talk is going to be like, what happened at University College Dublin? Everyone's going around talking all funny. Anywho, let's conclude here. So going back to the Jensen Ramirez family, at the advice of a friend, Helena reached out to a psychologist or a psychiatrist who specialized working with families. The whole family attended for 8 one-hour virtual sessions of emotion-focused family therapy. This provided a space for the family to process the difficult emotions that have corresponded to the significant changes as of late. Victor and Helena learned about becoming emotion coaches for Mary and Louisa, and learned that the discussion of emotions in their own relations had rekindled a sense of closeness and intimacy. This led to Helena talking to Victor about his drinking, and Victor letting Helena know that he felt ignored and lonely. While things are still hard and the girls miss their friends, the girls' difficult behaviors have reduced and the family's doing better. The family still plans on going for their weekly outings to the parks through the winter months. Okay. So coming back full circle to our initial learning objectives for the day, here are your takeaways. 1, COVID-19 gets inside the family by clustering household risks and also making siblings more different from one another, which is probably a rough go for one parent-child dyad within the family. 2, COVID-19 stressors do not exist in a vacuum. They're additive or interactive with the effects of early life adversity. So again, always having a trauma-informed lens in addition to family systems and thinking about our cases. And lastly, following from the first 2 points, our telehealth approaches must be considerate of the way in which these stressors emanate across the family. I'm going to skip that. I'm going to skip my Mr. Rogers quote because I want to end on time. And and anyway, thank you to everyone. This is my lab here. We're meeting on Zoom. Thank you again for the invitation. Thank you for your attention. And with that, we'll open it up.
Thank you so much, Dillon. We might move from the screen to a picture of everybody.
Great.
So I spent time with my kids when I was young in the States, and I loved, well, actually, I won't say I loved Mr. Rogers, but certainly my kids loved him. So I'm very disappointed. You'll have to share that quote with me later.
I'll send it to you personally.
Yeah, thanks. I also loved your cramped acronym. I'm somebody who has to remember things by using acronyms. So just on a good one like that, it is cause for celebration. But your study is intriguing. I was not aware that there's a differential parenting effect based on lower socioeconomic difference. I mean, of course, having children myself and even seeing it in patients who come into the service, you are aware that there's a difference of parenting and relationship between parents and different children. And obviously some of that is optimal. That's the way it should be. A parent is sensitive to the needs of children and they modify their parenting strategies. But in terms of that differential response and negativity, I wasn't aware that it was based on socioeconomic status. And I wonder whether you might say something about why you think that is or what's driving that?
Mm-hmm. Yes, absolutely. So first of all, I fully agree that our, I'm getting a little feedback here, maybe if I turn down my speaker. Our way that we measure differential parenting, including the way that it was measured in this current study, does not get at that level of nuance where there is a normative and even a functional element of it in that, you know, sometimes you need to meet the needs of the child. So this is it's more of a crude measure that's just based on the dispersion in the quantitative outcome. In terms of why it is higher in low SCS families, that's a fairly replicated finding across the literature now. And the idea is coming from a resource dilution framework in that when caregivers Psychological resources are pressured due to economic demands. There's a spillover effect in that they might have less time, patience, psychological resources, whatever, to more intentionally and equitably parent across the sibling subsystem. That is, they're stressed out, so they might be more reactive to the kid who's having more difficulties, or they might express more favor to the kid who's relatively easier to parent.
Do you think that you know that socioeconomic I suppose confounder is just that it's more difficult to parent, and so you know your ability to be aware of and to manipulate or modify your parenting, you know, you've less capacity to do that? Or is it a function of, in the lower socioeconomic group, the prevalence of mental health problems in general in the parent and in the child, and maybe the types of mental health problems are also slightly different?
Yeah, I think that's an excellent point. And let's see, so in that model, what do we have? So we do have socioeconomic status kind of going to the parenting and also going to the child effect. And so those relations would be, I guess, partitioned for the variation associated with socioeconomic status. That being said, I don't think that those ways of statistically controlling for the variation fully capture all of the vast differences that exist across the socioeconomic continuum. So yes, I think it is likely multifaceted. It's a caregiver resource dilution piece, and we know that there's clustering, greater clustering of psychopathology broadly defined in low SES settings, in addition to other challenges too. So if parents are having, a chronic health condition at the time, that's another thing. So it really is, I think, a cumulative idea. And my thinking regarding it is more inclusive than exclusive, as in it's, likely not one specific mechanism. It's likely a number of cumulative stressors taking place that kind of spreads that parenting out, in addition to having lower means, so more negativity, less positivity overall.
You also mentioned, I mean, the caregiver burden, even without COVID, just normal parenting, there's a caregiver burden. You're juggling things, you're juggling relationships, adult relationships, jobs, or whatever. And I guess within psychiatry, people are aware of that. One group that is felt to have a higher caregiver burden than even individuals caring for somebody with schizophrenia is that of eating disorders. So the diagnosis itself, adversely affects or raises caregiver burden. Within the study that you did, you used the SDQ, so that isn't great actually at picking up eating disorder cohorts. But even looking at the other diagnostic categories, was there any sense that the type of diagnosis or problem area that the child had predicted in any way the change in caregiver burden? Like, is a hyperactive child who's cramped at home going to be much more difficult to manage, and not going to school, and you having to try and do the educational support as a parent who might yourself have ADHD, is that group higher risk for increasing caregiver burden?
Yeah, it's an interesting question. So we have not looked at the data that way yet. So that was the first study that I did, was the SDQ. The cramp study using the PROMIS measures, depression, anxiety, and also this anger measure that they have. So those are measures that do have clinically meaningful scoring, so that we do derive a percentile, we do derive a kind of clinical range. However, we've only looked at those measures continuously now. We do have data on whether or not there is a diagnosed condition. I imagine, given the sample, it would somewhat approximate the population prevalence, perhaps a little higher because it's COVID-19. However, we've not looked at the data in that way to see if, so one question would be, even within a family, if one child has a diagnosis of ADHD and the other sibling doesn't have a diagnosis of ADHD, how are the dynamics playing out? But the associations that we've looked at so far are all linear and continuous associations, and we have not looked at the data in a categorical fashion.
Have you either looked at it by way of, you said there was no difference apart from the substance misuse in terms of fathers or mothers, but again, I'm not sure, what about whether you're, a stay-at-home parent, and so either working at home currently or, not working outside of the house, or is there any benefit to escaping to work, or in the case of the scenario presented, working overtime in a hospital setting, I suppose it's the possibility of looking at, what's driving that negativity. Is it the fact that your own resources, you're not having those met? There's no, I suppose, way of you de-stressing in other situations as opposed to being physically present at home with the children.
Mm-hmm. Mm-hmm. Yeah. And so right now, that would be indexed by our COVID-19 disruption scale. We have not done any sort of stratified analyses to look at how, whether or not the caregiver was currently working at home before the pandemic, if those effects would be different than caregivers who continued to work, or caregivers who, went to work for the first time during the pandemic, and so on. There's, a couple different configurations it could look like there. One of the reasons that we haven't got into that is because the model that I presented to you, that path model, is a bit computationally intensive. Our sample is not tiny, but so it's 1,000 kids, 500 families. And because of that, that clustering, we start to run into, I guess, sample size and power issues if we try to run too many sub analyses. We didn't have any specific hypotheses related to that at the time of the initial paper. However, I think they're really important questions and certainly things to consider.
Because you were talking about school closures, and obviously there's a huge amount of stress when somebody has to shift to work from home, the student themselves. But it's thinking about if having the kids at home while they're trying to study in some ways increases the mental health distress. It's the unintended consequences really of restrictions. Obviously you're trying to minimize, spread of the virus, but you're also trying to minimize the adverse effects of neither schooling, neither socialization for the kid, but also the risk of increased parent negativity and how that's going to magnify the problems.
That's right.
You were saying to me earlier about the school system in Canada, where it's optional for some parents whether they choose to continue with their children online or whether the child might go in face-to-face in school. Is there any sense of how those choices are made, or why those choices are made, and whether there's any differential impact on the children who were able to continue to go to school reasonably safely, continue to socialize, and maybe experience a slightly better home environment as a consequence?
Yeah, it was interesting. So my hypothesis when the optional approach was rolled out was that, I think a lot of in terms of social determinants of health. So I was thinking that the higher SES families, they're going to keep their kids home because those are the parents who are more likely to have white collar jobs that are amenable to virtual work. I was completely wrong. It was flipped. So now there is some data showing that in Toronto, where there are hundreds of thousands of students, the students who are in school are from families who are higher socioeconomic status. and the kids who are at home are of lower socioeconomic status. The verdict is still out on what the learning and mental health outcomes of this remarkable natural experiment are going to be. Though we can kind of speculate on what the reason for that is. My thinking was, okay, so parents who have resources, they're going to keep their kids home because they want to, avoid the pandemic and that kind of thing. But they're not. They're sending their kids more to school, and the lower resource families are keeping their kids home. Clinically, what I'm seeing, so a lot of my more high risk families, they're just not having the fight about school refusal. The kids are refusing. I'm not going to school. The parents said, whatever, your older brother will take care of you. And then they go off to their work as an essential worker. So I would imagine that there probably will be some measurable outcomes of this. There are folks who study the learning gap that takes place over the summer. This has been, 10 months of disrupted schooling. So yeah, I guess we'll see. I'd be curious to hear how it's playing out in Ireland.
I guess in Ireland, it's probably, obviously parents can choose not to send their kids to school, but there isn't that same, offer of, would you like to or not. Most schools that would be open, the expectation would be that all kids would go in, but there is a little bit of parental choice. And my own sense is, I think when schools are open, kids are delighted to go. But the way you're describing it there, where the lower socioeconomic group are more likely to stay at home, it's a real risk of further increasing the disparities, because those children are already not attaining as well. Their ability to engage in online learning, even by way of the equipment, but especially if, as you're depicting in just that example, if parental supervision or interest in supporting the academic side, there's going to be huge, drops in their attainment levels. And you do worry about the cycle just repeating itself. Where there's poor motivation to study, where there's poor ability, where there's poor performance, and that leads to, less interest in it overall. So I think it's a great opportunity, to look at that in Canada, where there is that, natural experiment that you'll be able to do, and maybe tease out who's making those decisions. Is it the kid who's choosing not to go, or is it just practically easier for a parent not to get the kid up and get them dressed and stress out about getting them to school when they themselves have to rush off to work? Could I just end with, I know we're running out of time, Dillon, but could I just end with maybe moving from COVID and maybe you giving the audience just, an overview of the salience of the ACEs and, whether they are indeed additive, whether there's some experiences children have, but the salience that they give to them as they mature, negates the negative effect, and therefore they're no longer predictive of mental health problems, and maybe which adverse experiences are much more toxic to children, that even with early intervention or a positive framework, they still continue to carry that risk of mental health difficulties with them.
Yes. So I should say as a disclaimer that I do not view the ACEs necessarily as the truth through which we should see all of our research and all of our clinical thinking on early adversity. I use them in these epidemiological studies because they're useful, and they often convey a strong signal in terms of predicting psychopathology across the lifespan. In terms of whether they're linear or cumulative, in this study we modeled them as a linear function. So 0, 1, 2, 3, 4 as a line as opposed to as a curve, though a number of studies have suggested that the 4 or more is where you get the bang for your buck. Now, that being said, another limitation of any cumulative risk index, and the ACEs are a special case of a cumulative risk index, is that each of those cumulative risks are equally weighted. So we're weighting sexual abuse with divorce the same, which is crazy. So I've done some of my own person-centered research around trying to pull apart the ACEs and say, okay, what are the risk profiles, and where do we really need to be thinking about those particular types of ACEs? And the physical sexual abuse, for sure, I think are the really important ones. Emotional abuse, neglect. I think some of the other ones kind of give you a flavor of what home was like. Parent with a substance use problem, parent incarcerated, that's kind of indexing SES as well there. So I'd say really thinking about the early physical, sexual abuse, emotional neglect, physical neglect, those maltreatment, the childhood maltreatment outcomes as being particularly salient.
Dillon, we've run out of time, unfortunately. I think, and I know the audience is mixed between child mental health clinicians and those working in adult and other areas. I think it goes back to the fact that within child, we're so aware of, as you said at the beginning of your talk, the family systems, the importance of not just searching for psychopathology, but looking for the impact of developmental experiences, family issues. I want to use my own acronym, which I'm equally delighted is a good one. It's called IF-ME, and it looks at the individual aspects, whether it's psychopathology or presentation, with F standing for the family, mental health issues, but also the parenting structure, and including that negativity that you've mentioned. M for the medical and the neurodevelopmental aspects, and E for the environmental. And obviously that's both SES, but also school experiences or bullying or whatever. And so we are well used to assessing children in that very comprehensive aspect, and then applying that to the treatment interventions. So we share with you very much that family systems lens that you were talking about. And our adult colleagues, we hope, are increasingly realizing the importance of advocating for child and mental health services and resources, which sadly we're not getting as much as we need. And that's an area we as clinicians have to continue to advocate for. But so to go back to your kind of your emotional coaching, I guess, you know, I feel our child psychiatry collective pain. You know, I don't know, the emotional support, we're there with you. And the practical thing is, all of us out there, let's continue to talk to the HSE. You're doing the good work in Canada, Dillon, about the research that's going to improve our ability to give real data. But let's try and get more resources for child psychiatry. I've taken up a lot of everybody's time. Christmas is only very nervously a couple of weeks away, because there's not a Christmas light or decoration in my house. So I'll have to start focusing on that soon. But I want to wish all our attendees, you know, a very happy, healthy and peaceful holiday period as we're coming up to it. I know within mental health services, we're often very busy because of those stresses that are on all our families and patients. I want to alert you to the slide there is talking about a professional certificate in child welfare and protection in the clinical environment through the UCD school. And this is because they are funding a number of places on some of our master's and diploma programs, and please have a look at that. I just want to announce the next, we're having a break now for the Christmas period, and our next speaker is Professor Adrian James, who's the president of the Royal College of Psychiatry in the UK. And Adrian is going to kick off on the 8th of January. So please do all join us for that and come back to us. I don't think there's any more announcements, Nora, is there, that I haven't mentioned? No, but just to thank everybody for attending every Friday, and to thank Dillon once again for a fantastic talk today. Take care, everybody. All the best.
Thank you. It was my pleasure.